delaying further, it's my privilege to introduce the first speaker. Um, the first speaker is Dr. Tushar B. Jagzape. He's a professor in pediatrics at All India Institute of Medical Science, Raipur. To his credit, he has 44 publications in various reputed journals, 6 book chapters. He's organizing secretary. He was organizing secretary in ASPICon 2022, conducted at AIIMS Raipur, and a member of editorial advisory board at Indian Journal of Pediatrics, as well as past executive body member of Environmental and Child Health Group of IAP. He was also executive member secretary of IEC and received a lot many awards, including Best Poster Award in Respiratory Section in Pedicon 2018. His most means the areas of his interest are including childhood allergy and asthma, general pediatrics, medical education, and sickle cell disease. So I welcome you, sir. You can start your presentation. Thank you.
Thank you very much, madam. A very good afternoon to all those who have joined here. At the outset, I would like to thank SASPI for giving this opportunity. After ASPICon 2022, I actually lost touch with the SASPI, and this session has given me an opportunity to again get connected with the esteemed faculties and members of SASPI. I would like request SASPI office to please share the presentation. Can you? Yeah. So my topic today is about what I would like to discuss today about optimizing antimicrobial use in OPD and what are the strategies to overcome this challenge. So basically, as you could see in my interest, that I like general pediatrics, and general OPD practice is very an important aspect of general pediatrics, and that's why this topic is kind of, I think, an important one. So let's see what are the contents of today's presentation would be. What is the prevalence of antibiotic use in OPD practice? What are the unique problems which we face in antibiotic prescription in OPD? What are the components of antibiotic stewardship? And what are the challenges in implementing the antimicrobial stewardship in OPD settings? So, as we know, OPD is an area where the care is provided without an overnight stay, and India is the largest consumer of antibiotics in the world. And out of the OPD prescriptions, almost 25 to 50% OPD prescriptions contain antibiotic. And we know that overuse of antibiotics significantly contributes to the antimicrobial stewardship, antimicrobial resistance. And that's why the World Health Assembly has identified AMR as one of the top 10 global public health and development threats. Next, please. Next slide, please. So, out of these prescriptions, let us see how many of these antibiotic prescriptions are rational or they are rationally prescribed in the OPD. As per the CDC, almost 30 to 50% of the OPD antibiotic prescriptions are inappropriate. And there was one study published by one of our members, senior members from PGI, about how many prescriptions are actually rational in the OPD. And as you can see here, a very interesting figure that only 5% of the diarrheal antibiotic, only 5% of the prescription in diarrheal diseases were actually rational, and around 70% of prescription in the respiratory diseases, antibiotic prescriptions were irrational. Next, please. So what are the common indications of using antibiotics in the OPD? Commonly, we use or antibiotics are required when there are suspected bacterial infection. Though bloodstream infections are serious, but the common OPD condition like typhoid and even bacterial pneumonias. So if the typhoid is not severe or not complicated, OPD antibiotic, it can be managed in the OPD, and definitely antibiotics are required in that. dysentery or dysentery specifically, I'm not talking of diarrheal diseases because diarrheal diseases do not need antibiotic. Streptococcus sore throat, skin and soft tissue infections, non-severe or uncomplicated bacterial pneumonia, as well as urinary tract infections. These are the conditions where antibiotics are needed in OPD practice. Next, please. Now, let us see this case. This is a real case. A 60-year-old female who visited the emergency department with complaint of cough, cold, and undocumented fever for 2 days. And she complained of chest pain for 1 day, and that's why she visited the emergency department. She is a known case of bronchial asthma and was not taking medications regularly. And she did not have any other comorbid conditions. Next, please. So here, this is the prescription in the emergency department at the time of discharge. And as you can see here, the patient has been advised about 2 antibiotics, augmentin and azithromycin. So we will evaluate this case subsequently with the in the subsequent present slides. Next, please. So what are the challenges in prescribing antibiotics in the OPD or any ambulatory setting? The first is patient load and inadequate time, because a lot of patients, they come in the OPD or the emergency department. There is not enough time to take appropriate history and do clinical examination. And we just want, like, this patient should be disposed as early as possible. So that is one challenge. Next, please. Then there are challenges, especially when we talk of routine OPD. The physician has a perception that patient need antibiotic. Patients also sometimes expect that when I come to the doctor should give me antibiotic. Next, please. And in the OPD, there is limited access to diagnostic tests. We cannot go for some blood investigations or some other. Sometimes we can go for some RDTs or some X-rays and other investigations, but they are not routinely available or not routinely asked for. And then many times when the patients, they come, like suppose the disease is evolving, there is a history of fever for 1 day, then some certain symptoms will come afterwards or in the subsequent disease. So when we ask the patient to come for follow-up, many times it is difficult for the patient to come for follow-up. They are lost to the follow-up. And last but not the least is the self-medication. Many patients, they take antibiotics by their own over the counter. Next, please. Next, please. So what are the practical solutions to this? Though there are specific guidelines and criteria or principles of antibiotic given by the CDC, the practical solutions are, the most important would be to take a good clinical history. With the help of history and using the clinical acumen, it is very imperative on the part of anybody who is taking care of OPD patients to reach to a provisional diagnosis. Many times it may not be possible to reach at a specific diagnosis, but at least reaching to a syndromic diagnosis might help you, like whether it is a say diarrheal illness, or it's a respiratory problem, or some other things. That syndromic diagnosis, or even tropical fever, that's the syndromic diagnosis, might help for using appropriate treatment options. And then whenever the clinician, based on the history and syndromic diagnosis, thinks that there is a need for prescribing antibiotic, then whenever possible and wherever available, the standard treatment guidelines should be used to choose the appropriate dose and duration of the antibiotics. The standard treatment guidelines are, though they are given by the WHO, the ICMR, and also like in pediatrics, the Indian Academy of Pediatrics has also come with the standard treatment guidelines for many of the common illnesses which we come across the OPD, and that any clinician can use for according to their specialty. Then always use narrow spectrum antibiotic and give proper indication to the patient about how much, when to take the medication, how long the medication should be taken, And if the antibiotic is not being prescribed, or the disease is in a very early stage, then clear instructions when to come back, and take help of the clinician or the medical facility. Now, coming to the initial steps for implementing antimicrobial stewardship in the OPD practice. Next, please. This again is a next, please. So these are few steps for implementation of AIIMS in OPD setting. The most important one is identifying high priority conditions. What are high priority? We will subsequently see this in details in the subsequent slide. But high priority conditions are those conditions where the clinician tend to use antibiotics or trying to deviate from the standard treatment guidelines or good clinical practices. Next, please. Then next thing would be to identify why these standard treatment guidelines are being not followed, or what are the barriers to deviate from the best practices. Next, please. Then the thing is to establish standards for antimicrobial prescription, like giving, like as I told about the standard treatment guidelines, what antibiotic to use, what dose and duration should be established. Then many times when the patient, especially in tertiary care centers or hospital setting, when the patient is coming, there is some expectation from the patient to go for some investigations, and doctors also tend to do certain investigations which may actually be inappropriate and may lead to antibiotic use. For example, a typical case of bronchiolitis in an infant or say 1-year-old child, a typical case of bronchiolitis, when the patient comes in the emergency in the hospital, X-rays are advised most of the time, and by looking at the X-ray, many of these patients are started on antibiotics. And next, please. And another last but not the least is de-labeling of drug allergies. This I'm going to talk about. I'm going to kind of share one case, because we do not have drug allergies, though they are common, but they are not as common as being reported by the patients. Many patients, they feel, I am allergic to this drug, I am allergic to that drug. And there are certain hospitals where the drug allergies are tested by giving an injectable drug intravenously. Truly speaking, apart from penicillin, drug allergy antibiotic sensitivity testing is not required. And many times the drug, when it is put in, is injected intravenously, you can get some swelling. So we had one case of syphilis in a pregnant lady, and when she was tested for penicillin, she developed some swelling. And though though she did not have any systemic reaction, but she was labeled as having sensitivity to penicillin, and she came to us, and we gave her amoxicillin challenge and kind of delabeled her from the penicillin sensitivity. So many times by delabeling, not for proving, but by delabeling the drug allergies, we can prevent use of broad spectrum antibiotics in the patients. Next, please. So first step, like of the initial step, was recognizing high priority conditions with opportunities for improving antimicrobial prescription. So as I already told in the previous slide, that these are what are high priority conditions. They are the conditions where clinicians commonly deviate from best practice. It can lead to over prescription of antibiotics, under prescription of antibiotics, or even misprescription of antibiotics. So these are the examples. This table gives some example, like overprescribed. Most of the studies, and you will find that, and in general also you will find that respiratory infections, mostly the upper respiratory infections, are the condition where antibiotics are very commonly prescribed, not only by the clinicians, but also patients themselves go and take antibiotics from the over the counter. Then there are conditions which need antibiotic, but they are overdiagnosed, leading to overuse of antibiotics. Say, for example, streptococcal pharyngitis. So we do have very specific criteria, though sometimes it might be difficult to differentiate whether it is a streptococcal pharyngitis or it's a viral pharyngitis. But there are certain scoring systems are available, like Centaur scoring or Mike Isaac scoring, which helps to identify whether it is streptococcal pharyngitis or not. And then you can, but many times the doctors do not use those, and just by kind of looking at the enlarged tonsils and congested tonsils, which are very common in pediatric age group because of the natural overgrowth of lymphoid tissue, and then that leads to increased antibiotic prescription. Then there could be certain conditions where antibiotics may not be required in the beginning until unless they get complicated, like acute otitis media, sinusitis. There are also conditions where antibiotics are underused because many of these diseases are not picked up, like sexually transmitted disease. And again, respiratory conditions are the conditions where wrong agent or wrong doses may be used. Many times we see that the general practitioners or private practitioners tend to use third generation cephalosporin or even cefixime for upper respiratory tract infections. Next, please. So, what are the reasons for deviation from the best practices? The most important reason is knowledge gap. Many times there is a knowledge gap, that is the clinician is not aware of the diagnostic criteria or what is the standard treatment, or even if they are aware, they tend to kind of over a period of time come under pressure by the pharmaceutical companies or peer pressure or the patient's expectation. Like many times they perceive that the patient's need or the patient wants antibiotic. And there was one survey conducted by the CDC where 54% of the providers, they believe that the patient expect antibiotic for cough and cold. But that in reality, only 26% of the patient responded or said that yeah, they wanted the antibiotic for URI. And so this is the mismatch between the perception. And the another thing is, if there are kind of established clinical pathways like the diagnostic criteria and the standard treatment guidelines, if they are practiced, they are put into practice, that may reduce the antibiotic used. Next, please. So in this case, in the index case which we saw, the patient was a known case of asthma, and she had chest pain breathlessness. That means she had asthma exacerbation, and she was not compliant with the inhalers. So what was needed in this patient was probably education about the disease, education about the proper use of inhalers, and not the antibiotics. Coming to the next case, it's a 4-year-old boy, a 4-year-old child who was well nourished, was brought with complaint of loose motion 6 to 8 times for 2 days. And there was history of low-grade fever and 2 episodes of vomiting. There is no history of blood in the stools. So this is a typical case of acute watery diarrhea, and almost 50 to 60% of cases in this kind of patients would receive some or other form of antibiotics. Not only would they receive antibiotics, but a very irrational combination of ofloxacin or ranitidine like drugs. Next, please. So by using making a syndromic diagnosis and implementation of best practice guideline will help in reducing the antibiotic prescription in these patients. In this child, the syndromic diagnosis is acute watery diarrhea, and it does not need antibiotic. And the standard treatment for such kind of acute diarrheal illness is ORS and zinc, which will be sufficient in most of the cases. Next, please. Another example of how or when the improper requisition for doing some test can affect the antibiotic prescription. So this is a 10-year-old female child brought with complaint of fever for 3 days. There are no other complaints. Examination was essentially normal. Somebody advised CBC, blood culture, and urine examination because there were no localizing signs. Next, please. So the urine routine was normal except for 3-2 pus cells, and there were a few epithelial cells per high power field, and urine culture showed growth of E. coli. So this is a very common scenario where you actually the urine examination was not warranted in this case because the patient did not have any symptoms suggestive of urinary tract infection. but still it was sent, because many times in children we do not get any specific findings. But then evaluating or kind of interpreting the urine reports or results is very, very difficult. Like, we have to see how the urine was collected, uh, whether the routine microscopy is showing adequate amount of pulses to say that there is pyuria, and then only if there is growth is there, then you have to treat. So this is an unwarranted investigation, and I also in such settings you can simply, in OPD we can use urine dipstick test, which is a very good, especially use of nitrates, and leukocyte stress. They are kind of specific. So if you have symptoms and you can't get a culture, at least if you do a urine test, and if it is negative for nitrates and negative for leukocyte stress, antibiotics may be avoided. We can also in such cases make use of rapid diagnostic test, like available for, suppose this patient would have come in monsoon season, then I would have thought of doing rapid diagnostic test for dengue or malaria. This kind of test can be useful, and we are going to see about those tests by our subsequent speaker, Dr. Pragya will talk about it. Next, please. Coming to the core elements of OPD antimicrobial stewardship given by CDC. So these are the 4 core elements, that is commitment, action for policy and practice, tracking and reporting, education and expertise. Next, please. So commitment, this commitment is from both the caregiver, the leadership, and also from the patients. So just by kind of written display of commitments to support antimicrobial stewardship helps in bringing down the antibiotic prescription. Many times you can display the boards, you can write that about the AIIMS program, and identify a single leader to direct stewardship activities. Whenever it is advisable that this stewardship related duties should be included in the job responsibility of the person, like those who are new recruits or nursing officers, they should be aware of this antimicrobial stewardship. Next, please. Action for policy and practice. So it's very important that we should use evidence-based diagnostic criteria and treatment recommendations, as we have previously seen. Then there should be good communication training for clinicians. As a clinician, as a doctor, we hardly get trained in the communication skills, but nowadays there are communication skill labs, and communication is being taught to the undergraduates by the ETCOM model, but specific communications related to antibiotic use is required. Then support for clinical decisions, especially OPDs are managed by the junior doctors. So whether to prescribe antibiotics or not, they may get support from the senior doctors. Then accountability. Whenever somebody is prescribing some antibiotics or non-recommended antibiotics, that person should kind of write in the documentation what was the reason for prescribing those antibiotics. And last is watchful waiting or delayed prescription, which is not very commonly used in India, but I think it's a good practice, especially when the patient is coming on day 1 and day 2 with some throat infection or respiratory infection. Call the patient or give the patient about give the patient antibiotic prescription, but ask them not to take those antibiotics. Give them drugs which can have good symptomatic relief, and then they can come back or use the prescription if required after a delay of around 72 hours or so. Next, please. Then tracking and reporting of the antimicrobial use. This can be, though maybe difficult for an individual OPD setting, but in institutes this can be done. This can be done both at the individual level as well as hospital level. At the individual level, somebody who is interested, who is an antibiotic steward, may self-evaluate how commonly he or she is using antibiotics. He or she can upgrade his or her knowledge by participating in the CMEs and workshops for AIIMS or quality improvement. And at the hospital level, audit and feedback can be done, and feedback can be provided. Tracking of appropriate diagnostic criteria, tracking and reporting for high priority conditions like what diagnostic criteria were used, what antimicrobials were prescribed, whether the dose were correct and duration was correct or not. Then it is advisable to individualize this tracking and provide individual feedback. Comparison with other peers may be helpful, and antimicrobial resistant reporting, ADR reporting, that is adverse reaction because of antibiotics, this reporting also should be increased because that will help in improving the practices. Next, please. And last core is education and expertise, and I think this is the most important core, that is effective patient education is needed for antibiotics use. Patient should be told when antibiotics are required, when are they not required, what is the harm of antibiotics. They may not be aware of the resistance, but they should be told about how they are going to affect long term, like increased risk of allergies, increased risk of asthma, increased risk of hypertension or diabetes. All these things should be told to the patients. And education of all staff in antibiotic stations, like so that they have a consistent message. Like it should not happen if somebody is going to one prescription, consultant is prescribing no antibiotics and the other is prescribing a lot of antibiotics for the same condition. And ensure timely help from expert counsel. Next, please. In short, about the AMSP in outpatient setting. So in parenteral use of antimicrobial in outpatient setting. So it is use of IV antibiotics when there is no overnight hospital stay. This can be done in the home or hospital. Next, please. And when can be used? When the patient is stable. Especially this can be done when the patients are being shifted. Like it can reduce the hospital stay. So the patient should be stable. There should be adequate support from the family and society, and no infection-related complications, and support from the hospital. So whenever required, the patient can come to the emergency. In India, this is quite commonly practiced, but it is not kind of formal. Like many private practitioners put an IV line and bring the patient, ask the patient to come morning, evening for the antibiotics. These are the infections where this can be done, like cellulitis, infective endocarditis, especially continuation of the antibiotics, bone and joint infection, and in the later stage of CNS infection, like in neonate or in pediatric meningitis, neonates require 21 days of antibiotics. So they can go and come receive the antibiotics on the OPD. Next, please.
Sir, I request to conclude.
Sure. Last 2-3 slides. So there are certain benefits of this, it reduces the duration of hospital stay, reduces the cost for patients. It is comfort which is required. Next, please. But there are certain risks also. Line-related issues, overuse of IV antibiotics, and wrong choice of antimicrobials. Like because only IV lines they can give IV antibiotics, they should not choose antibiotics which are broad spectrum. And there are similar principles required, like right dose, right drug, right duration. Next, please. So this was a study published by one of our members about outpatient antimicrobial parenteral therapy in Indian settings. Next, please. Last 2-3 slides. So these are other settings where we can do it. So what are the hurdles? Next, please. Hurdles are basically challenges related to staffing and engagement. Like whenever the staff goes changes, these practices which are established may be lost. The leadership may not be ready to reduce the to use this AMSP program. So we need advocacy, we need research and capacity building, and then evaluation of any SOPs that can lead to overdiagnosis where antibiotics may be used. So these are the common hurdles. To summarize, OPD setting is a high antibiotic use area. The core components are 4, and most important component is awareness and education. And there is no single therapy. It is not. There should be a tailor-made approach for each setting. It will be different for hospital, different for the private practitioners and single practitioners. Thank you. Next, please. This is the bibliography. Next, please. Thank you.